And let me ask ChatGPT, independent, totally independent, what it thinks. Okay. Okay, if a clinical trial with a randomized withdrawal phase of 6 months after a 12-month open label phase showed a small benefit for a drug that had a p-value of 0.476, how would you interpret this data? The drug group was open label for 12 months and was split in half to continue drug or go on placebo. I mean, this is really not something that I think, oh, we got somebody to talk to here. Hello, I gave you speaker, so if you can't speak, just come back and talk. And so I just asked ChatGPT, and I'm going to read what ChatGPT had to say. The p-value indicates that the difference between drug and placebo groups during the randomized withdrawal phase is not statistically significant. In fact, this p-value suggests a high likelihood that the observed difference could be due to random chance rather than the true effect of the drug. Now keep in mind, the true effect is very small. So even if that true effect was real, which they're saying it's due to chance, but even if that was real, that's not enough to be a drug. Okay. Here's how to interpret the results in the trial design. Statistical implications. A p-value of 0.476 is far from the conventional threshold of stat sig, which is 0.05. This means there is no strong evidence that the drug provides a meaningful benefit over placebo during the withdrawal phase. Small benefits observed may be attributed to variability or noise rather than a reliable drug effect. The withdrawal phase is designed to test the durability or continued effect of the drug. If the drug was effective in open label, one would expect a significant difference between drug and placebo during the withdrawal phase, assuming the drug has a sustained or protective effect. The lack of stat sig raises questions about whether the observed benefits during open label phase were due to the drug or due to other factors, such as natural disease progression, placebo effects, or bias introduced by the open label nature of the initial phase. That's right, open label trials are biased. This is like very, very simple to understand. Open label designs can introduce bias. This is why we don't trust them. And if this is the first time you're gonna get burned by open label study, listen, I've been burned by them before myself. I've been in your exact shoes and I've seen open label is not worth the paper it's written on because you need a control group. It's not science without a control group. So they can introduce bias as both patients and investigators are aware of the treatment. That awareness can influence outcomes, particularly subjective measures. Any observed benefit during the open label phase may not translate into an objective benefit during the more rigorous randomized phase. This is the rigorous part. This is the only rigorous thing this company's ever done. And it did not go well. As ChatGPT has no axe to grind, right? Zero bias. Okay? Clinical relevance. Even though the p-value is not significant, it's important to assess the effect size and clinical relevance. If the benefit is small, further investigations may be warranted. This benefit is so small. I made a comparison of other Alzheimer's drugs, and I showed you that it is one of the smallest ever seen that still got developed. Dimebon was big, but failed in phase 3 anyway. The Cassava drug that Vivek and I worked on, that he developed, I passed on, was so small people ridiculed us for even bothering, and then of course it failed as it dropped dramatically in phase 3. Same thing with bapineuzumab. Same thing with lecanemab and donanemab. So why won't semifilam go from 0.6 to 0.2, 0.3? So let me do another thing that would be really interesting. Let me okay, let me do this. This will be fun. Okay, I'm just gonna paste, because like I really think, again, with all respect in the world, I really think this is just a black and white thing. It's not open. Quite frankly, in my opinion, it is not open to interpretation. So I'm gonna do something crazy here. I'm gonna change this. Watch this. This is nuts. Okay, I'm gonna change this so it says open label, and I'm just gonna change this to drug 1. Watch this. I've never done this before. This is a really good idea. I think AI is pretty smart. You know, it's not always perfect, but let's see. Open label. Drug 1. I'll make this a little smaller. And then I'm going to do it here too. I'm going to remove anything that says Cassava. Okay, I'm going to remove even this detail, which is bad for the company, so I'll make that a benefit. I'm going to give it a complete, yeah, it is an Oxytrex sequel. I'm going to give it a complete unidentifiable look. There's no bias whatsoever. It's not going to know that this was from a certain presentation. It's not in the ChatGPT data set, since this is from a presentation screenshot or live PDF. And I'm taking the drug names out of it. And I'm going to do it with a line ChatGPT instance, so it's not biased by my prior questions. Oops. Okay. Okay, that's GIF 1, I want to show it, and then GIF 2, I want to show it this. And again, I'm going to strip out everything. Imagine it says it all in, this is good data. I'll cover my short, I'll tell you that. Okay, this doesn't say semifilam anywhere, right? Okay, good. Temporary chat, that clears the memory. Okay. Please examine the data I have provided. The chart and table are data from a phase 2 controlled withdrawal study of drug 1, a potential drug for Alzheimer's. What is your percentage chance that a phase 3 trial succeeds, showing an ADAS COG benefit of significance, 1 or 2 points or more? I know that giving a probability is difficult, but please give me your best guess regardless, and I will come up with my own research to determine my probability and share that with you. Okay, is that fair? Should I change anything? Randomized. It is controlled. It is controlled. It's randomized withdrawal, and it's controlled. It's placebo-controlled, and it's blinded. What's also bizarre is that I'm not sure that they randomized it correctly, but that's another story. All right. Let's see how it goes. Yeah, this is the control group, right? The light blue and the light yellow lines. Does anybody in the chat room want to chat about Cassava? This is all people that I already know, I think. So I was hoping somebody from the Cassava side wants to talk.
I guess not.
That's fine. Well, it's a lot more bullish than I am, I'll say that. It says the mild subgroup shows promising trends. Phase 3 could succeed if the study was powered for this subgroup and excludes moderate AD patients where no effect was observed. Well, they did not exclude moderate patients. That's a big chunk of their trial. They said phase 3 typically needs 0.05 and clear clinical benefit. Achieving this narrow patient selection, optimizing dose, and controlling variability. They said that a 30 to 40% chance. Yeah, I think that it is very, very low. I think it is close to 0. But yeah, if somebody wants to talk, they can. I don't see anybody speaking in the Discord. There's a lot of people that joined. I'm not sure why. Yeah, I don't think ChatGPT is right, by the way. But 30 to 40% is... I mean, I could challenge ChatGPT the same thing. This is a post hoc. The mild subgroup is a post hoc observation, which also failed at a nominal, non-adjusted p-value. Why are you so excited about this subgroup? Now, it's going to just tell me I'm right, so I know how that works. So don't be too surprised by that. But yeah, maybe we should try Claude. Maybe we should try Claude. Why mild AD is still worth considering cautiously. Now, this doesn't have anything to do with the fact that the guy got indicted, the other phase 2 data was doctored, the mechanism doesn't make sense. There's a whole bunch of reasons. But if ChatGPT is saying 30 to 40%, I'll accept that. But we have a lot of other issues. See, this is really fun. Instead of moving straight to phase 3, just do a phase 2b, which is totally right. Replicate this result before you do a phase 3. So given the additional context that the mild subgroup was defined post hoc and failed nominal significance, it dropped it to 20 or 30%. It's still not right, but it's getting closer. And I can continue to argue with GPT and get it to 0, I'm sure. But it's, not exactly a reliable interlocutor. Now, I could try to do the opposite and say, wow, this is a really good result. Don't you think it's going to work? But let me see if I can come up with some more ideas here. Why would there be a biological rationale that mild and moderate are different at all? Shouldn't we just trust the all-comers population where the p-value was a p.46 and the ADAS cog change was 0.56 better than placebo, which is very small relative to other medicines? Again, it'll keep dropping it. It's not that surprising. I don't know how to do Discord that well. You can go to the Everyone Can Speak chat. Let me see if I can create an invite there. And then I can drag you in. There's the Discord. And just tell me what your Discord name is, and I'll bring you up. They said that approved AD drugs like donepezil and memantine typically show 2 to 3 points on ADAS-Cog over placebo, which is considered the lower limit. That is the lower limit, 2 or 3 points. 2 or 3 points over placebo. Lower limit of clinical relevance. This is half a point, and if you believe they're mild bullshit, it is 1 point, which is not a whole lot more. Even if you believe they're bullshit about mild, which is you should not. You're talking about 1 point. Yeah, it's hard to believe in this. Probability, revised probability of success, 20% or less. I can use O1, but it doesn't. O1 doesn't let you post pictures. A lot of my friends work at OpenAI, so don't. I know more about how to use ChatGPT than almost anybody. I mean, there's a chance with this data in isolation, but the story gets worse. The protein target for this drug is filamin A. Please revise the drug in question is a small molecule. Please revise your probabilities and give me a specific probability to the percentage point, not a range. I mean, I'm friends with virtually... Okay, we can use Claude if you want. I have Claude, you know.
All right, you got this, kid.
All right, thank you for setting it up. We can try
Probably
Claude.
the biotech.
All right, let me post the same pictures for Claude. Copy. I'll use the same prompt. Okay, let's see what Claude thinks. Some people think Claude is smarter. I don't. I'm also an investor in OpenAI. For full disclosure. Okay, given these factors, I would estimate a 15 to 20% chance of success in phase 3. My reasoning, the phase 2 data shows minimal efficacy signals, high p-values, and confidence intervals crossing 0. However, there is some evidence of biological activity and a consistent direction of effect. Phase 3 typically needs stronger phase 2 signals to succeed. That's right, phase 3 typically needs stronger phase 2 signals to succeed. What other factors are you considering? The mechanism of action of the drug is a small molecule which binds filamin. Using that information, please revise your estimate and give a specific percentage. I mean, I'm not making this stuff up. If you guys say, well, you got to take into account for the disease-modifying nature of the drug and how it has this long-acting thing, that is not normal. If you don't believe me, again, an impartial observer, ChatGPT and Claude, we all think there's no chance. Now, maybe you're a genius, but okay, here's I said filamin, and it said, this additional mechanistic information about filamin binding is quite important and causes me to significantly revise my estimate downward. Here's why. Filament-binding molecules typically affect cytoskeletal arrangements and protein trafficking. While filament is involved in APP processing and has some connection to tau, this mechanism seems quite upstream and indirect for achieving meaningful cognitive benefits. The biological distance between target engagement, which is filament binding, and the desired outcome, cognitive improvement, is quite long, with many intervening steps. Small molecules targeting protein-protein interactions historically have had challenges, and specifically with achieving target engagement in the brain. Combined with minimal efficacy, no dose response, high p-values, wide confidence intervals crossing 0, limited separation from placebo, I revised my estimate to 8%. This made me more pessimistic because it suggests the phase 2 signals may reflect fundamental limitations in the approach. Let me give you some more information. The drug does cross the blood-brain barrier. It binds to a specific region of filament very potently. The work of Dr. Wang, who has published some research on this drug, has been called into question, but only assume that is relevant if you are relying on Dr. Wang's research. Otherwise, disregard. The half-life of the drug is 4.5 hours. What else can we tell it? In phase 2A at 28 days, which is a very short time frame and should not necessarily reflect any prospects of the drug, there was no change in a memory test. The drug is very safe. No publications have been released of phase 2 data. The only controlled data available is the data you have. Given all this information, I would revise my estimate to 5% chance of phase 3 success. A particularly concerning aspect is that even with good blood-brain barrier penetrance, which I'm making up, I don't even know if that's true, and potent binding, which I'm also making up and I don't know if that's true, we're not seeing clear signals in the controlled withdrawal study. The short half-life means we may not be getting sustained target engagement despite the potent binding. I didn't say it was short, I just gave the number. Okay, let me try to be nice to it. The open label data was very good. Even without a control group, the patients in one subgroup did remarkably well with no decline in cognitive function. The other subgroup declined, and I'm being nice here, declined as rapidly as one expects in Alzheimer's, which is not true. They actually decline worse. But let's try to make Claude like it. Let's see what it thinks. I'm not mentioning that the CEO was accused of fraud or all this other stuff because it's maybe not that important. But I did want to mention one thing about the mechanism. Yes. The company hypothesizes that filament A interacts with nicotinic receptor alpha 7, and that by stopping this interaction, I'm not even sure what the fuck the company is saying. They will benefit patients by avoiding A beta 42 binding to alpha 7. What are your updated thoughts? I don't know. This, to me, is exercise in tomfoolery. Okay, let's see. I'm now revising my probability estimate up to 25%. Okay. Alpha 7 is a yes, but all the alpha 7 drugs have failed. It's a well-validated target 20 years ago. Now, unfortunately, I don't know. That's why I'm asking you. I'm revising my probability down to 10%. Okay. One more thing. The co-founder or the co-discoverer of the medicine was indicted for fraud. Keep in mind that the fraud was limited to a very small number of Western blots, and he has not been convicted yet either. There is no known fraud regarding the clinical trials. In a court of law, one is presumed innocent until proven guilty. What is your probability after this information? I'm revising my probability to 4%. The fraud indictment, while limited, adds another layer of uncertainty to an already challenging picture. Combined with the historical failure of Alpha 7 approaches and other concerns, it's harder to maintain confidence in the program. And again, I think I'm being kind. I told it had remarkable open label results. Remarkable. I'm not giving it my best shot here. Are you aware of any filament A binding partners that could potentially help the cause of this filament A small molecule binder? In Alzheimer's. See, it's funny. It says APP has an interaction with filament A. I would revise to 6%, but what information did you use to see that filament A binds to APP? The reason I ask is if it was Dr. Wang's work, keep in mind he has been arrested. I should have not cited the filament A interaction without being certain that it came from validated non-compromising sources. I need to lower my probability estimate to 3%. I am looking for you to tell me any paper which suggests filament A binds to a relevant target in Alzheimer's that does not come from Dr. Wang. Yoris. I do not have confidence in citing any interactions. I was inappropriately pattern matching and making assumptions without solid, verifiable sources. Alpha 7 I have no reason to believe alpha 7 actually binds filament A. Even if it did, as we discussed, alpha 7 drugs have not done well in the clinic, and there is considerable distance between binding and effect. I need to revise my probability down to 1%. If this company was publicly traded and was trading for 1.3 billion valuation, what is your assessment of that valuation? For this valuation to make sense, if successful, the drug would need to generate enormous revenues because we need to account for the probability of failure, development costs, time, competitive landscape. The implied value, if successful, would be $130 billion. The NPV would be far less. The valuation seems extremely high. I would estimate fair value to be closer to 100 to 200 million. That is correct. I mean, this thing is just a joke, dude. If you have to learn biotech lessons through this company, then again, my girl is going to make me a cassava cake apparently, so I'm happy about that. But if anybody's out there that wants to talk about this, again, I think this is the part I want to focus in on. I have a lot of other parts like we can dissect into.